Hi, my name's Dr. Kelly Hawkins. I'm an assistant professor of medicine and infectious diseases at the University of Colorado. So we're going to be talking about re-engaging patients with HIV and mental health comorbidities into care. So mental health comorbidities play a huge role in care engagement for people living with HIV. Approximately half of all people with HIV have at least one mental health comorbidity. We know that this can lead to negative outcomes along each step of the HIV care continuum. Mental health comorbidities often overlap with other challenges that present barriers to care, such as negative social determinants of health, stigma, and substance use disorder. People with HIV and mental health comorbidities are less likely to achieve viral suppression than those without mental health comorbidities. We know that mental health comorbidities can lead to apathy about healthcare, which in turn can lead to missed appointments, difficulties with adherence. We also know that depression is significantly related to retention and care. It's really important to know routine assessment is the first step to understanding somebody's mental health needs. There are numerous screening tools available. However, often these are not done. Maybe there's lack of capacity during appointments. We know that there are many competing priorities of what needs to be done during a medical appointment. There's stigma around mental health, and maybe there's lack of a referral process or a way to follow up on needs identified by screening tools. So it is essential that there is some sort of process by which there's treatment or referral if needs are identified on these assessments. And below we have some of these examples of questionnaires that can be used as screening tools. The PHQ-2 looks for depression. The GAD-2 is an anxiety screening tool. And then there is the screening tool for PTSD. So there are a lot of potential solutions when improving access to mental health care. Screening can be shifted to providers other than mental health professionals. This is also known as task shifting. Perhaps screening can occur when a patient's being roomed for a primary care visit. This can be done by an MA, for example. Intervention intensity can be triaged based on the patient's need. Oftentimes, it's really helpful to incorporate peer navigators into this process who can really help with this linkage piece and address some of the stigma that surrounds mental health. Applying treatment methodologies to co-occurring mental health comorbidities, such as depression and anxiety, can be very helpful as well. And then again, adding low barrier solutions to accessing mental health care, such as incorporating telehealth or internet-based cognitive behavioral therapy. We know that integration of HIV care and mental health services is critical for access to care. And so there are different models and ways to do this. And this can be at the clinical, organizational, or system level. And this produces better HIV outcomes and adherence. And so this graphic gives an example of integrated care using case managers. From there, you can access mental health care and other aspects of behavioral health care, such as substance use disorder treatment. This can all be done in a single facility, or it can be a multi-facility integration where service providers will refer to more specialized care. And this all leads to more of an integrated system that integrates both the mental health sector, the HIV sector, with the primary care sector. So what are some specific strategies to engage people with HIV who have mental health comorbidities back into care? Integration of mental health services into HIV care is critical, as mentioned previously, and this can be done through collaborative care, merging services, co-locating care, or creating treatment plans that take into account both HIV and mental care. Case managers can be used to help coordinate care. Warm handoffs can be really helpful. A primary care provider providing a warm handoff to a mental health provider can really jumpstart a relationship. Trauma-informed care is critical in these situations. Taking patient preferences into account when referring to mental health professionals can go a long way as well. Considerations such as race or gender preferences can be considered. Further, We can combat stigma through peer support, partners, families, friends, and just acknowledging that there's a lot of stigma around mental health. Providing patient-centered care to address HIV and mental health comorbidities has been shown to be very effective. So this particular intervention focused on patients with mental health comorbidities who had a history of missed appointments and medication interruptions. They provided integrated community-based pharmacists with medical providers and built upon existing medication therapy management models. They collaborated to identify therapy-related problems and implemented quarterly follow-up pharmacy visits. And what we can see is this integrated model improved retention and care and viral suppression across the board, both in patients with HIV and patients who had HIV and substance use disorder. So how can routine screening be incorporated into practice, and how can clinicians help patients easily access mental health care? Many of the things that were discussed previously in these slides can really help make mental health care more accessible. So things such as warm handoffs between providers, co-locating care. Oftentimes it's very overwhelming to manage your health care, especially if you're facing other barriers to care, such as homelessness and mental health disorders. And so co-locating care can really take some of the burden off the patient and make needed services much more accessible.